to Health Literacy Out Loud. I'm Helen Osborne, President of Health Literacy Consulting, founder of Health Literacy Month, and author of the book Health Literacy from A to Z. I also produce and host this podcast series, Health Literacy Out Loud. Today, I'm talking with Dr. Joanna Ando, who is an ophthalmology resident at the Johns Hopkins Wilmer Eye Institute in Baltimore, Maryland. Joanna has a long-standing passion for both the sciences and humanities. Her interests include social determinants of diabetic retinopathy, domestic violence-related ocular injuries, and geographic healthcare disparities. Joanna is passionate about using scientific and narrative writing to elevate marginalized communities. In 2023, I happened upon a one-page opinion piece written by Joanna and published in the Journal of the American Medical Association. It was titled, "The Stories We Don't Know," and its focus was on family histories, an otherwise very routine part of medical care. This piece not only was beautifully written, but also very meaningful to me. I am thrilled that Joanna agreed to be a guest on Health Literacy Out Loud. Welcome.
Thank you so much, Helen, for having me on Health Literacy Out Loud. And I'm honored that my piece and my narrative medicine piece had resonated with you.
It resonated to me at a professional level about health literacy and health communication, but also on a personal level because there are gaps and questions I cannot answer in my family history, and I kind of hate getting that form sometimes. So let's take this from the beginning. Family history. I think that's a routine part of care. It's certainly routine when I'm a patient. Tell me about this from the doctor perspective.
Yeah, so I give a brief introduction as to, especially as a trainee, what our introduction to family history is. And oftentimes it's seen along a long checklist of things within the history of presenting illness. And so it's seen as something as we have to ask. We have to make sure that we ask thoroughly. And if we get an answer, okay, we make note of it. If we don't, we kind of keep moving on. And I think for me personally, especially in clinical practice, especially with the day-to-day stressors of clinical practice, health history or family health history doesn't end up being a very prominent part of the medical interview, especially say if you're in the emergency department or if you're in an acute setting and you're just trying to figure out your differential diagnosis. So I found it kind of wavering in terms of how much we gave so much credence to it. But if there was something that a patient would outwardly forthright say, colon cancer runs in my family, my mother had ovarian cancer, I would see how clinicians, it would tip off different alarm bells and kind of set a different course of their management. So for me, I saw it as something that came and went in terms of how prominent it was in the medical interview. But if a patient brought or had that information, it set a different tone for the clinical encounter.
Thank you. But I'm just curious, but we need to go into this. Out of all the patients you see over the course of a day or a week, month, whatever, is it a large percentage that have something relevant come out of the family history? Or is it just one more thing you just check off and you move on to something more meaningful?
I think it's oftentimes one more thing you check off and keep moving. I'd say across a day, if I were to see, say, a dozen patients, maybe one or two would have a positive family history or something that once I ask, they would be able to give me more detail.
Okay, so you talked about asking about, so it's interesting, that's a part, so even if it takes a minute on your part, that's an important minute in every patient encounter, and it's payoff or what you learn by this doesn't sound to be all that meaningful in that way. What are the ways that you ask or find out from patients about their family history? I'm thinking of just this checklist, but is there another way, or is it really just the checklist?
I think I find it interesting because within the medical record, the electronic medical record, there is a lot of automatic input that will say, is there hypertension, diabetes, history of stroke, history of myocardial infarction. Sometimes it'll use more of these medical-centered, doctor-centered terms. And I find that sometimes asking that directly to patients, it ends up being, I mentioned in my narrative medicine editorial, like this elephant in the room. How many people are going to say, oh, yes, my so-and-so had a history of pancreatitis when they were this age. So it's in terms of technicalities, oftentimes I reframe it. Well, now I'm more of especially in ophthalmology and more in vision health, instead of asking, say, about glaucoma or a retinal detachment, I'll say, are there any instances of unexplained blindness in your family? Or did anyone in your family go blind?
Oh,
Or
okay.
if, say, patients sometimes will get mixed up, and understandably so, between, say, glaucoma and cataracts. And so they'll say, oh, my so-and-so had cataract surgery. And so sometimes I'll have to ask a little bit more detail. Was this necessary eye surgery? Was this elective or by choice eye surgery? So I try to use, and I think the term patient-centric can also be subjective, but I try to use more generic terms and see what patients can yield, because it's always interesting in that interaction to see them racking their own brain and saying, oh, yes, so-and-so or uncle so-and-so had this weird disease and he said he needed this laser surgery. So sometimes it's interesting to be working backwards through someone's family history in real time, because I think more open generic questions helps to prompt that spark of memory.
Right. So you're really translating that medical ease. Who's the one who writes these family histories? I mean, I go to a health plan, so that's usually the same group of providers, but it's usually a yes or no question. It has this list, like 2-column list of like all these dread things that can happen. And you have to then have follow-up questions on that. Is that something that's designed at each center, or is that a federal requirement, or do you know where the origin is of that?
That is a great question. I actually don't know the origin of that. I think within, the health system I use is Epic, which is quite common in a lot of American US health systems. And within Epic, there's a lot of inputs you can put in a patient's chart, and it'll always auto-populate in a note. So if you're doing, say, history and physical or a progress note, it'll auto-populate. But
Auto-populate means what?
auto-populate meaning that it will go from the area where it's almost like you put your settings in your profile. Every patient has a profile, and you can put profile settings, everything from their phone number to their address. And there's an area where you put family history, and some of it are yes or no tabs that you can enter. And those tabs are then automatically transferred to a note that any clinician may choose to write moving forward. It's nice because it allows for that information to come forward. And so not everyone has to ask those questions every time, and you can see it. If someone was astute enough to ask the question and put it in the profile, and now it's transferred to your note. But it's also an area where sometimes people would just skip over it because it's all just automatically transferred information. So sometimes people are just skipping over to the areas that they're going to type. So there's a give and take with that feature, but I think it's helpful because once it's in the electronic medical record, someone can always refer back to it if they're trying to say, hey, what is this patient's family history? But I don't think in real practice many people do that.
Okay. That's just really interesting for something that happens in every patient encounter or every new patient encounter, and it's not always so meaningful. I want to take this in two directions. Let's start with the benefits as you see them of a family history. And then I really want to be talking about reasons people cannot provide it or what you do about that. And I'm also thinking of my own stories too. So from your perspective, as someone who's thought about this an extra amount, what are you hoping to learn by a patient's family history?
I think it's interesting because from the way that a patient describes their family history, I already get a sense of how open or close are they to their family members, not only their immediate family members, but their extended family members. For someone to say they know their uncle went blind means that there was some type of vulnerable conversation which that relative was able to share what they were going through. So that gives me insight into how close are they to their family or their unit. And then it also gives me a sense as to what their generational history of having access to healthcare is. Because sometimes I have patients who will say, my family just did not have access to doctors like that. So that's why I don't have a family history. And so oftentimes patients are very aware of why they might not know. So it'll also give me a clue into that. It'll give me a clue into also their own health literacy. Are they saying a patient, their family member went blind? Are they saying their family member had glaucoma and had a glaucoma tube surgery? So
So you're talking about because of word choice.
Yes, word choice as well. So
okay.
And so that's why for me too, I like to keep it open-ended in terms of how I ask about it, because I think that oftentimes yields more answers into someone's understanding of their disease, there's understanding of any genetic or familial connections to the disease, and then that opens up a larger conversation.
Can you give us all an example? We're not in your doctor's office.
Yeah.
I want to hear of how you would go from what some patient tells you, some information, and how you would expand on that and turn that into something that's meaningful.
Yeah, so I'll give an example. Several weeks ago, I was in the clinic room with a younger patient, and she was having some symptoms of dry eye. Oftentimes, dry eye can be due to a lot of things. We're on computer screens a lot of times, but oftentimes you also want to rule out things like thyroid eye disease. So the thyroid is one of the main organs in the body, and oftentimes when the thyroid is more hyperactive, meaning very active, it can cause symptoms of dry eye. And so for me, I was a little more targeted in my question, but I was asking her if she had any history of thyroid issues, if she had family members who had thyroid issues. And in that moment, she said, oh, I think one of my relatives, one of my aunts had it. And then she was able to call her mother and then talk in real time during the clinical visit and clarify.
While you're with her.
Yeah, at that time. And so it was convenient enough for her because she felt comfortable enough to talk to her mother. And then at that time, they were able to clarify, oh, yes, it was so-and-so. They didn't have surgery. They didn't have any eye issues. And then we were able to close that loop. But with that information, once I'm presenting to my attending doctor, that's the doctor that I work under and the doctor who is the main attending in the clinic, I'm able to convey all that information. And then he goes into the clinic visit different. This isn't just a patient with dry eye. This is a patient with dry eye who has a family history of thyroid eye disease.
Oh, this one did have the family history.
Yes, and she did. So once she called her mother, she found out that her aunt did have thyroid issues. So now it's not just a patient coming in with dry eye. It's a patient who doesn't have recent thyroid studies with dry eye and a family history of thyroid disease in her maternal aunt. And so those two narratives, and a lot of times in medicine, it's how we frame the patient. We're already creating our own story or biases. And sometimes we have to, in order to come to a decision and come to a treatment plan, we do have to come up with a hypothesis. Mm-hmm. And family history can, like I was mentioning, it becomes relevant in certain areas or not. We kind of, I think as clinicians, we dabble in it as we see it fit. Another quick example is, say, colon cancer. Now, the national guidelines are that patients who have an immediate relative with colon cancer should be screened, I believe, at least 10 years earlier. And so you can imagine someone, and I mentioned this example too, two people who do have family members with colon cancer, maybe one of their family members maybe just happened to be able to get a colonoscopy and get diagnosed. There's no difference between two people who know and don't know other than their relatives who were able to get access to care to know.
So someone who didn't have access to care but might have indeed have a family member who died of it or was very sick with it but didn't have access to all that testing and diagnostic and
follow-up. So you can see how that compounds because they're going to their primary care doctor and their primary care doctor is going to recommend whether they get a colonoscopy now or in 10 years.
Which can make a major difference in somebody's life. So from your perspective, I am thrilled that you are looking at the family history rather than just being one more checkbox. These examples, you're just sharing how valuable it can be, whether to rule in something or rule out something, make a different treatment recommendation. Let's talk about why people have trouble filling this out. And I'm going to start on this. From all the work I've been doing in health literacy, I've gone to some conferences of adult readers who are learning to read, adults who are learning to read. And It was a wonderful conference. It was in Iowa many years ago, and they talked about the family history. A whole bunch of people, not collectively, but one here and one there talked about it, and talked about that form you get. There's usually 2 columns filled with all those big words and a yes/no box. And more than once, I heard people say, you know what? I don't understand this form. I don't know the answer. So it's just easier if I check no to all the questions because there's no follow-up. So certainly someone who is a struggling reader, from that small section of people I spoke with, are choosing not to fill that out. I talked about some gaps in my family too. Some significant relatives died very young. I do not have their family history. We've lost touch with that side of the family, and I don't have it. So I can't answer all those questions. So that's certainly a part that strikes me when I know that they're reaching for something. It's just, I don't know.
Yeah.
And I'm thinking people who have even less history than that, someone who might be adopted or, whatever their life circumstances, it can be very hard. Or I know for me, I just do it matter-of-factly at this point, but there were some gulp moments when I wish I knew information and I can't add. What are you finding in your practice and in your life and with colleagues? Why are people struggling with the family history?
Yeah, I think there's a lot of factors. Some of them are macro, some of them are micro. In terms of micro, oftentimes it's just the way we interrelate with our relatives, and whether within certain cultures, whether we do share diagnoses, whether we do share news from doctors, or whether we go to appointments alone versus go to appointments with people.
Oh, okay.
And so I think those just social interactions compound and dictate whether there is a wider knowledge of not only your health, but your family's health. And again, I think this is culture dependent, this is family dependent. And I think sometimes it takes a health crisis for people to also band together and be more open about it. So I think that's one aspect. And then you have larger aspects in which families have been separated either by transcontinental migration, immigration, colonization, slavery, or just not even interacting with the healthcare system due to mistrust. And I think these are larger mechanisms that for people to not engage in the healthcare system, oftentimes they are very valid in that decision. We have a lot of historical examples such as the Tuskegee experiments, as well as even within the Holocaust, in which healthcare was not seen as a safe space. And so for many people, that is compounded generationally. And I'll have patients who say, I never go to the doctor. And even when they go to the doctor, it's really bad. And so you have that individual, you sometimes have those individual beliefs that are very much rooted in historical misdoings within medicine and within medicine as a field. So I don't want to blame the individual as much. And I think it's very easy to do that, especially when someone comes in and they're diagnosed with stage 3 colon cancer. And you wonder, how did they let this get so bad? How did we forget the ways in which medicine and healthcare system are not friendly to interact with, whether it's co-pays, insurance, scheduling appointments. And so again, I think it's compounded on both sides, but the effect is that you have that not only on the individual, but family units and generations across decades. So my interest in health disparities and health equities, I think a lot of it has been in the here and now, especially with COVID and other type of, a lot of acute health crises. But I think it's hard to want to deal with health disparities now without recognizing that we're also dealing with a compounded linear effect. It's not just a pinpoint in time. Disparities are also now compounded across centuries.
Wow.
Which can be overwhelming, but that's why I try to pose some of these rhetorical questions, opinion editorial as well.
Well, you're talking about the issues, and the term generational health is really resonating with me. Another factor that I've learned along the way, even from doing some podcast interviews, are people who are deaf or hard of hearing. They might miss some of that family information that's just
Absolutely.
kind of chatted about in an informal way rather than like, so and so has this disease. It would be, it would be like, did you hear this? Did you hear that? And the person who might be deaf or hard of hearing may not have heard it.
Yeah.
So, in the bit of time we have together, what can people be doing about this? And I just want to know from a few perspectives. Our listeners to Health Literacy Out Loud, a lot of clinicians, a lot of people in public health, might be in community organizations. And we all, at some time, will be patients and family members and caregivers. Few strategies you can help us out now that we're kind of making clear what the issues are?
I would say I'll start kind of more personal, and then from the perspective of the patient, and then from the perspective of a healthcare provider. So I'd say from the perspective of just a person as a family member, because I think everyone who is listening, we are all someone's family member.
Right.
And I think there's a moment when we will all have a diagnosis, and there's this idea of, do you share it? Do you want to share it? Who would you share it with? And I think the answer should be yes to all of those. But I also want to have a more cultural, competent approach to it, because I know within certain cultures, sharing diagnoses can also be seen as taboos. But I implore everyone as a family member to someone to think about that, the idea of generational health and the idea of sharing that vulnerable space with your family members for the sake of opening that dialogue and opening that discussion. So that's what I would say on the family member level. I think there's also something powerful in terms of being able to support your family members in doctor's appointments. Oftentimes we're spewing out a lot of information, and just having one set of ears, it can be overwhelming. And I see oftentimes family members who have their spouse or their sister or their uncle in the room. It just helps to have multiple stories as to what happened, what's the diagnosis, how do we move forward. And so I think there's something to be said about accompanying each other within doctor's visits, because it can be overwhelming and not all that information settles at once. So that's what I would say from the individual or family level. From the patient level, I think it's recognizing that not knowing is not the same as not having a family history.
Well
and
said.
you talking about the clipboard and filling out everything and just wanting to say no, 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 or none.
Right.
When patients do it, I think it enables clinicians to do the same. And so I always appreciate when patients do say, not that I'm aware of, not that I know of, because
Okay.
whether they know it or not, that's a conscious understanding that they're not saying, no, I don't have a history of lupus or rheumatoid arthritis in my family. I just don't know. And so acknowledging that your uncertainty, I think that still allows space for answers or stories to still be collected. So that's what I would say on the patient level. And in the same vein, if you do know, be your own advocate, be your family's advocate. I think the anecdote of the patient calling their mother in real time and being able to clarify, it only takes a couple minutes, and I don't stop patients from doing that if that's something that they want to clarify.
I'm so glad you shared that example. Then I'm so glad you did that. Wonderful.
And in the age of technology, that's a surrogate for not having your family member in the room.
Right.
So that's what I would say. And then on the clinician level, it's the same way I'm saying for patients, not knowing is not the same as none or not having a history. And I think always knowing that the question of, do you have a family history of this or this? It's always going to be a touchy question, because you need a certain level of privilege, you need a certain level of health literacy, you need a certain level of generational stability, wealth, access to healthcare to be able to answer that question. And someone may be the first within their family to have a coordinated healthcare system, a coordinated healthcare plan.
Wow.
That now they're developing their own stories. So realizing that, and realizing the power of open-ended questions when trying to suss out unexplained deaths, premature deaths, severe late-stage diagnoses, It could be anything from ranging of, did anybody die prematurely, or anyone die early in your family? Did anyone go blind in your family? Are there any unexplained illnesses in your family? It kind of starting a conversation like that. And then if you do have to do the check mark of high blood pressure, diabetes, hypertension, that's worth doing as well. But at least having that open to try and spark those stories, try and spark that. And then on another level too, in terms of policy, and especially in the world of personalized medicine, genetics, medical genetics, this is a hierarchy of medicine that I think many people are still trying to learn about. And like I said, the more health literacy and privilege and understanding of your own health conditions, the more you're able to access that tier of medical genetics and personalized medicine. So I think especially those within those fields specifically, trying to understand how can there be already compounded healthcare disparities within the people who even access that field of medicine.
And Joanne, I have another recommendation too.
Yes, please, Helen.
I want you to go forth and tell everyone, tell this podcast, your paper was a start. This podcast is another start. You are making so clear to me, and I hope to all our listeners, about the value of something that might have been like a throwaway thing that people were doing, thinking something else was more important. Really bringing home its importance and giving tips and strategies to everyone. I am cheering you on.
Thank you
got
so much,
a
Helen.
big voice that'll get even bigger. Thank you so much for all you are doing and for sharing it with us on Health Literacy Out Loud.
Thank you so much, Helen, for opening this space and having this space for so many podcasts that you've been doing. It's a pleasure that my writing resonated with you, and I'm glad that we've been able to meet through this space to talk about it as well. It's been a real pleasure.
And your podcast is in a position of honor. It happens to be my 250th podcast.
Oh, yay. That's amazing.
And
no
so
pressure.
are you. And so are you. Thank you, Joanna.
Thank you, Helen.
As we just heard from Dr. Joanna Ando, it's important to consider all the many ways we learn and communicate with our patients and family members. And that includes learning about their family history or generational health. It's really a key part of who we are as patients and family members, and providers have so much to learn by that too. But communicating clearly about health is not always easy. For help communicating your health message, please take a look at my book, Health Literacy from A to Z. Feel free to also explore my website, healthliteracy.com, or contact me directly at helen@healthliteracy.com. New Health Literacy Out Loud interviews come out the first of every month. Get them all for free by subscribing at healthliteracyoutloud.com or wherever you get your podcasts. Please help spread the word about Health Literacy Out Loud. Together, let's tell the whole world why health literacy matters. Until next time, I'm Helen Osborne.